So the topics that I'll be covering is the basic anatomy, workup and staging, surgical management, especially focus on the lower rectal cancer, intrasphincteric, ELAP and TATME, and the status of laparoscopic and robotic surgery. This is the usual picture that you can see. There's a lot of confusion whether what is lower rectum, mid rectum, upper rectum, where the sigmoid ends, and where the rectum starts. So a lot of definitions were there. So to clear this, clear this confusion, there is an international consensus between all the radiologists which are involved in the radiological imaging of rectal cancer, including Gina Brown and all the those from whole the globe, and they came up with this definition that you have to identify neither at the sacral promontory nor the peritoneal reflection. You have to identify where the mesorectum, this is mesorectum, and where the U-shaped mesentery of the sigmoid starts. So where the mesorectum ends and the U-shaped mesentery of sigmoid starts, and that is the radiological definition of rectosigmoid junction. So anything above this is to be treated as colonic cancer. Anything below this is to be treated as rectal cancer. And that has been the most of the time dilemma, whether this is a rectum or a rectosigmoid or a distal sigmoid. So whether you need to give radiation or no need for radiation upfront surgery. That is why this clarification has come. So now we always use at our place the definition for this, where the rectal mesentery ends and the start of the U-shape. You can see this is the U-shaped mesentery of the sigmoid starts, and this is the rectosigmoid junction. So the local staging, I think Abhishek has covered. There is no doubt that MRI is the most important investigation for T staging of rectal cancer, and it is must at present to have a preoperative MRI for taking a decision. This I think also he must have covered, so I will not go in details. You can see, you can identify the lesion, whether it's a T1 or T2, or the mesorectum is involved or not. And if it is beyond, it is going to mesorectal fascia involving the vessels, then it becomes a T4. And this is the standardized format which was recommended by Gina Brown to be reported. And we have modified this at our place so that none of the findings are missed in the structural reporting of the CA rectum patients. And always you can note if the lymph nodes are outside of the primary drainage area, these are classified as M1A, not as the regional lymph nodes or N2 or N3. If the external iliac or common iliac nodes are involved in rectosigmoid or upper rectum, then it becomes an M1A, not a localized disease. So for metastatic workup, standard is CT abdomen and chest. We have been doing at our center a PET scan as a study protocol, but the standard of care is CT abdomen and chest. And if there is doubtful lesion, MRI with liver-specific contrast are better to delineate liver as well to know the exact extent of lesions. So coming to management, I think it has also covered. For resectable cancer, for T1 and T2, we have node negative, you can do either T3 or node positive in our setup. Rarely we find any early cancer or T1 or T2 without nodes. So most of the patient in our setup goes for neoadjuvant treatment and then taken up for surgery. This is all for T3 node positive, and I'll not go into detail of neoadjuvant chemoradiation, whether short course, long course, and especially coming to the superficial cancer. If rarely you come out with early cancer, T1 lesion, or a villous adenoma, you can do a local excision. If it is less than 1/3 circumference, well to moderately differentiated, no LVI or on the biopsy, and there is no metastasis on the investigations. There are a lot of approaches for local excision, but these transtoxyl and transantics are only for academics and usually never used. So I will the transanal excision, which can be done in the supine position or a prone jackknife position, depending on the location. If the tumor is anteriorly placed, then the jackknife position is better. For posteriorly, you can do a simple Lloyd Davis position. You can use a retractor. Lone star retractor is good for doing a transanal excision. And in this, you have to excise with a good margin, properly label it with all the margin and send it for biopsy. Immediately we send it especially for frozen section to for clear check the margins. This is one of our patient in which MRI staging showed either a T1 or T2 lesion. We did a transrectal endoscopic ultrasound. It was found to be a T1 lesion. This was endoscopic transrectal ultrasound, and in this it was confirmed that it is a T1 lesion and the muscles were clear. So we took up for transanal excision using a Lone Star detector. You can see the hooks are placed and then we excise it and close the defect using a V-lock suture. And this biopsy was a T1 with margins negative and no further treatment was required. And the TEM has been there for quite some time, but because of the cost involved in for such extensive costly instrumentation, it is most of the time not used. And this uses the CO2 insufflation to distend the rectum and do a transanal excision up to 12 to 14 centimeter of position. But the TEMS has changed because it is easily available with all the laparoscopic facilities. You can do all the lesions which are resected by TEMS by using TEMS. And this is a low cost. You can use laparoscopic instruments and using a gel port. There are two, either you can do a Sales port of Covidian or applied medical gel port. We have been using a gel port for these lesions. And especially you have to identify again for benign adenomas, neuroendocrine tumors, or well-differentiated T1 or N0 tumors. For lesions more than 5 centimeter. If lesions are less than 5 centimeter, you can place the TEMS port and the transanal excision is sufficient. For higher tumor, more than 5 centimeter, up to 12 to 14 centimeter, you can use the TEMS for doing a resection. This is the gel port which is used for transanal TEMS procedure. And you have to place this and then use the laparoscopic instrument through these ports and do a transanal excision. Coming to locally advanced rectal cancer, which are usually the most of the cases fall in this category. You can see there are, for upper rectal cancer, there is anterior section. Once the anastomosis is above the peritoneal section, it is called anterior section. If the anastomosis lies below the peritoneal section, then it is low anterior section. All the anastomosis lying at the level of pelvic floor is called ultra low anterior section, whether it is a colon anastomosis or intersphincter resection. But this is required for lower third tumor. The important development that has come in the decreasing the local recurrence was TME by Bill Hill, and which is the concept of excision of the rectum with an enveloping lymphovascular fatty tissue, taking all the fatty tissue along with the rectum under a sharp dissection and without any blunt dissection, preserve the injury to the pelvic artery nerves and decreases the local recurrence. For higher tumor, you can do a partial TME or partial mesorectal excision, in which around 5 centimeter margin you have to take, and this is called tumor-specific mesorectal excision. And if you are doing for mid-rectal tumors, a total TME is required. And this I will not go. I think Dr. Pasricha has covered all this for quality assessment of quality of mesorectum. This is always, it should be mentioned in the histopathology, whether it is a complete mesorectum, near complete or incomplete. Coming to margins, usually the problem comes with a positive CRM. The circumferential resection margin is important. If the tumor lies within 1 millimeter, then if the CRM is positive. And it can occur due to direct tumor extension or the mesorectal lymph nodes or any lymph tumor deposits. So TME helps in achieving negative CRM, and positive CRM is associated with the high local recurrence rate. For distal resection margin, for anterior section, a 5 centimeter margin is sufficient. For mid-rectal tumors, you can take 2 centimeter distal margin. For distal tumors, because you have to preserve the sphincters, so even a less than 1 centimeter margin should be okay if you have a negative margin on frozen section. For this, you have to send it for frozen section to confirm that the margin is negative for low rectal tumors. And this has been shown with a lot of studies in which you have shown that even with the distal resection margin less than 1 centimeter, you can achieve a good recurrence-free survival. And with the neoadjuvant chemoradiation, even a 5 to 10 millimeter margin is okay. This again, you can see a lot of studies have shown, even with a systemic review, the local recurrence rate was 1% more with margins less than 1 centimeter and 1.7% distal resection margin of 1 centimeter. But if you are doing the ultra low anterior section and trying to preserve, so even a negative margin should be okay, but it should be more than 1 mm or 2 mm margin. So this they have shown even a distal resection margin less than 1 centimeter have a local recurrence rate around 93% as compared to 95% with more than 5 centimeter margin, with more than 1 centimeter margin. So clear distal margin more than 1 meter is essential, even if it is not more 1 centimeter. So still the NCCN guidelines recommend 5 centimeter for upper tumors and try to get 1 to 2 centimeter margin for lower rectal tumors. But for ultra low resection, even it can be less than 1 centimeter margin. Coming to issue of the high versus low rectal margins, you can see that the randomized trial and meta-analysis has shown there is no difference in anastomotic leak, lymph nodal yield of 5-year survival if you do a high or low ligation of IMA. High ligation is important if you are planning a intersphincter resection or ultra low resection because it makes the ability of rectal colon to reach to the pelvic floor if you do a high ligation. But low ligation has been shown to have a better genitourinary function. If you do high ligation, the chances of injury to autonomic nerves slightly increases. So if you are not doing the ultra low intersection, you can just divide the IMA just beyond the takeoff of the left colic artery. Otherwise, for ultra low intersection, you go divide a higher up. So how to achieve distal resection margin in low rectal tumors and how we can achieve, that is the big question. So coming to management of low rectal cancer, it is important to identify what is low rectal cancer. Again, there is a lot of controversy. What is low rectum? NCCN recommend less than 5 centimeter, but most of the other centers use 7 or 7.5 centimeter from anal bulge is low rectal cancer. But Japanese use of peritoneal reflection as identifies for low rectal cancer, but we have been using a 7 or 7.5 centimeter margin. All tumors below 7 centimeter margin, we take as low rectal cancer for management. And that is why the low rectal tumors has been classified. This classification is very important and practical because in this you can see this is type 1. Here the tumor is lying more than 1 centimeter from the pelvic floor. This is levator and eye, and you have a possible chance of getting 1 centimeter margin just at the level of pelvic floor. So you can do either a staple colonal anastomosis or a hand-sealed conventional colonal anastomosis. This is called supraanal or type 1 low rectal tumor. For type 2 or juxtaanal, here that you are not able to get a 1 centimeter margin. In these patients, one should do a partial intersphincter resection with the anastomosis at the level of dentate line to get a good negative margin. This is intraanal if the tumor is going and involving the internal sphincter up to the dentate line, but the intersphincter groove is free. Then one can do a total ISR and with hand-sewn coloanal anastomosis. But if the tumor which is transanal or type 4 low rectal cancer, the tumor has involved the internal sphincter as well as intersphincter groove. So you can't preserve it to the sphincters, and then you have to do a APR or extra levator abdominal perennial excision. So this classification is very important in planning us or taking a surgical decision. The same you can see for type 1 colonal anastomosis, type 2 partial ISR, for type 3 total ISR, and for type 4 APR. Coming to intersphincter resection, this is where the internal sphincter is removed and with hand-sewn colon anastomosis. Again, there is classified as partial or subtotal or total, depending whether you remove a 1/3, 2/3 or complete removal of internal sphincters. But we follow a Japanese classification, that is total ISR, subtotal when we remove up to the dentate line. And if we are going beyond the total, beyond the dentate line, then it is a total intersphincter resection and we anastomosis at the intersphincter groove. So this is usually done for T2 to T1 to T3 tumors located around 1 to 5 centimeters from anal walls, and there should not be any metastasis. T4 tumors or involvement of external sphincter or contraindications, and always assess the preoperative sphincter function. Younger patient with good sphincter, external sphincter or squeeze pressure, they should be chosen for internal sphincter, ISR. For elderly patient, one should not select these patients for ISR because the chances of incontinence will be very high. This is the diagram you can show. You have to resect, go into internal sphincter groove, resect it, and down and do a colon-anastomosis and anastomosis. This is the plane. You do it close to the levator ani, and then go into the intersphincter groove and really along the adenoma fascia, you dissect, and then do a partial total or subtotal ISR. And always doing in the Lloyd Davis position and is important, and always use any adrenaline or lidocaine to take care of the bleeding. Use a lone star detector, identify the clear margin from the tumor, under vision, and if possible doubtful, then send it for frozen, and then do a colon anastomosis. This is one of our patients after a neoadjuvant chemoradiation. We did a ISR with anastomosis at the dentate line. So in most of the cases of intersphincter resection, you have to make a stoma. You can't leave it because it is too low and you can't take a chance. Always you have to divert. And if you see the complications, the mortality is almost similar to low intersection. Leak rate is around 4 to 10%, and overall morbidity is 7 to 30%. And you can see that you can achieve a arterial resection of 92 to 100% with distal resection margin or in distal around 5 to 22 centimeter. And it has shown that it is similar to after APR or pars colon anastomosis. So ISR is oncologically acceptable, and you can achieve a decent local recurrence rate even after preservation of sphincters. But important thing to note is there's always initially in the initial period, there may be slight incontinence, but the squeeze pressure gradually recovers with time and it reaches to the normal levels up to 12 months. So important thing to note is always choose a younger patient less than 50 or 55 years of age with good sphincter squeeze pressure for these procedures. You can see with lot of data with you can achieve incontinence continence in at least 60-70% of patients. Only grade 4 or grade 5 swelling is seen only in 5 to 20% of patients. So you can survey can say that most of the patients have shown around 70% they are satisfied with the ISR because they have got the normal passage with the preservation of the sphincters. Coming to the extra levator APR, this has come up because the APR was associated with the higher local recurrence rate. Because in conventional APR, you go close to the rectum at the level of pelvic floor, and the chances of getting the CRM positivity rate was high. And you have to get a wasting at the level of pelvic floor. To overcome this, the ELAP was proceed. In this, you can see that all the levators are taken at the level of this lateral pelvic margin. So there's no coning, and there you have a good margin and a specimen without any wasting at the level of pelvic floor. You can see this is the muscle you can see. So extra levator APR was described in 2007 because it improved the CRM positivity rate, tumor perforation, as well as recurrence rate were decreased, and the DFS and 5-year survival improved with this. Usually it is done in jackknife procedure because then you have a better access and you might need to excise the coccyx to get a better access. And the drawback remains that you need to reconstruct. But more with the availability of biological mesh, we have been using biological mesh or a fasciocutaneous flap to reconstruct. You can do it very easily. This is one of and this is the specimen. You can see there is no wasting at the level of pelvic floor. And if there is a lot of defect is there, then you have to use local VY advancement flap or a gluteus maximus flap. You might need to repair it. So this is the data which was published in 2010. It has shown the extraluate appearance associated with less CRM positivity rate, intraoperative perforation, and it decreases local recurrence rate. So to conclude, the IGLAP is better with conventional APR as compared to conventional APR, and the biological mesh is safe for reconstruction. Coming to transanal TME, which has come up recently, it is indicated for mid-rectal tumors, especially in obese males with a narrow pelvis. In this, you might do a transanal TME to get a good distal margin without any chance of perforation or CRM positivity there. For low rectal tumors, for T1 and T2, you can do a transanal TME with intersphincter dissection. But for T3 tumors, we have to do a conventional intersphincter dissection. These are two types of transanal TME, that is standard TME for tumors located more than 5 cm from verge. In this, you can take a pulse string here for after confirmation of the distal margin, put a gel port and do a transanal TME under the pneumorectum as well as pneumopelvis. Till the time you are doing a rectal dissection, it is under the pneumorectum. Once you reach the pelvis, then it is under pneumopelvis. For lower rectal tumors less than 5 cm forward, you have to do an intersphincter dissection first, followed by placing of the closure of the distal stem, and then do an intersphincter dissection or a TME transanally through the gel port after placing the port. Here also the same gel port is used, which was used for tennis. The anatomical basis is always you have to go along the longitudinal muscle fibers of rectal wall. You have to, from inside, you have to identify the rectal longitudinal fibers, and the most important critical areas 11 o'clock to 1 o'clock where the urethra is very close. So you have to be close to the longitudinal muscle fibers of rectum, and that is very important to avoid any injuries to urethra. And this is usually the plane. Here you start anteriorly, usually one has to start between 11 to 1 o'clock and divide the rectalysis, go anterior to the rectum and posterior to the prostate. Here you go to the levatorni along the coccyx, along the pelvic floor. So posteriorly it is not a problem. Problem is anteriorly to avoid the injury to urethra. And these are the dangerous points. You can see here there is not much. If you have in the plane, there is no chance of injuring the presacral vessels. The problem is in the anteriorly to avoid any injuries to vessels or urethra, and the laterally one should not go very lateral to injure the sacral nerves. So drawback remains the risk of urethral injuries, or also the recently few studies have come which have reported a higher level local recurrence rate, especially along the pelvic side walls. So in the Norway, it has been stopped to do TATME for the time being, but most of the other centers have not reported such results, neither from Japan or US. So coming to a word about minimum invasive surgery, there are a lot of data with MRC classic Korean trial have shown that you can achieve a similar CRM positivity rate as compared to open surgery. But these other two trials have shown that the CRM positivity rate was slightly higher in laparoscopic graft as compared to open rectal resection. But if you're in the long term, there was no difference in the local recurrence rate, disease-free survival, or overall survival, though the CRM positivity rate was higher in the laparoscopic graft in these two studies. So at present, with this all the last color to trial, it has shown that the CRM positivity rate was similar. The local recurrence rate was 5% in both the groups, and there was no difference in DFS and overall survival. So most of the centers are doing rectal surgery, but one should be careful in selecting patients, especially for low rectal tumors, because one should not compromise on the oncological outcomes. So coming to robotic surgery, these are various approaches, but generally now most of the centers are doing totally robotic and had gone beyond the hybrid or reverse hybrid techniques. There is a lot of data, but there are mostly case report or case series, and which have shown that it can be done with reasonable morbidity and mortality. But the most studies have reported around 28 or 40 cases with limited or shorter outcome. This was the only trial which was compared robot with the conventional laparoscopic trial, which is a rollout trial. And this, they have concluded there was no advantage over lab and there was no difference in urinary erectile dysfunction recovery. So at present, the laparoscopy and robot is the same. So practically, we feel for low rectal cancer, robot gives more convenience for surgeon to dissect and identify the planes as well as present the nerves. So to conclude, for MRI pelvis should be done for all rectal cancers for planning. For sphincter preservation can be afforded even in low rectal cancer for doing intersphincter resection or doing a transanal TME. Extra-levator APR is better oncologically than conventional APR, especially if the intersphincteric groove or levator NI is involved. Or TA TME can be useful in obese patients with narrow pelvis. Thank you.